Okay, are we live? All right, okay. Welcome everyone. I want to welcome you to our first session of the Food as Medicine Summit. I'm John Green from the University of Mississippi Center for Population Studies and also with the Delta Directions Consortium. I'm just going to kick us off to get us started. I'm going to ask Keith Fulcher from the Community Foundation Northwest Mississippi to welcome you. Keith?
Great, thank you, John. Keith Fulcher, Community Foundation of Northwest Mississippi. This is our annual report. I just put a copy of electronic copy in the chat box. So please read about what we've done and doing with our mission, which is connecting people who care with causes that matter. And one of the causes that matter that came up during the pandemic, thanks to Tom Pittman's leadership of the Community Foundation, is feeding, especially feeding the children. So that's what we've been involved in since March 1, is anything we can do to help bring food to those in need. So the major effort has been our Feed Fund. We call it Feed Northwest Mississippi. And since March 1, we've granted out close to $1 million. John, can everybody who's online see this, even though I can't see them? Okay, all right. So I'm just holding up a graph showing close to $1 million in Feed Fund grants that have gone to close to about 15 counties that we have been working with. And one of the projects was the Hunger Summit, started by the Brenda Smith at the Maddox Foundation Volunteer Center, and we funded that summit, and then now we're funding Delta Directions to do Food as Medicine. So we're very pleased and honored Community Foundation is part of this effort, which Tom Pittman will tie it up at the very end and tell you how long the Community Foundation has been involved with these types of efforts. I've only been there 18 months, but Tom and the staff, Community Foundation has been in this effort of health for years now. So John, if that's enough of a introduction, the Community Foundation of Northwest Mississippi is just pleased to be part of this.
All right, yeah, thank you so much, Keith. And for everybody who's joining us, to know that after our main presentations today, you'll hear from Brenda Smith with the Maddox Volunteer Center. And as Keith said, Tom Pittman will wrap us up. So I want to, again, welcome you to the Food as Medicine Summit. And as we did with the Feed Fund Hunger Summit sessions that Keith mentioned before, we'll be providing you with relevant information about how communities, organizations, and healthcare professionals and providers can implement innovative methods for improving health outcomes in the state of Mississippi. This summit series will focus special attention on how healthy and nutritious foods can positively impact health beyond the ways we often think of as medicine. Each month, we'll have partners present on topics related to food as medicine, bringing together a wide range of stakeholders and specialists, ranging from community organizations and healthcare providers to even food producers. This series is brought to you through a collaboration between the Community Foundation of Northwest Mississippi, Maddox Volunteer Center, and the Delta Directions Consortium. Consisting of a multi-institutional collaborative, the Delta Directions Consortium brings together universities, nonprofit organizations, and philanthropic organizations to address social and health concerns and to hope to contribute to health and economic renewal in the Mississippi Delta. Today, to get us started, our speakers will introduce you to the Food as Medicine framework and present an applied example from the Mississippi Delta involving several University of Mississippi and James C. Kennedy Wellness Center partners. Discussion will include what we can learn from this case, as well as broader applicability of the Food as Medicine framework for other community programs and future policy, thinking through challenges and opportunities and building for the future. And one of our goals beyond connecting people and networking and exchanging information with these summits is that following this series of summits, we'll also be working on kind of a strategic plan for what Food as Medicine can look like for the Delta region. So to kick us off, we have Drs. Annie Kafer and Dr. Megan Rosenthal. I'd like to do an introduction for them, and then I'll turn it over to Lynn to give us some instructions about how we'll handle Q&A. Dr. Annie Kafer is Assistant Professor of Sociology in the University of Mississippi Department of Sociology and Anthropology. And she also serves as an affiliate research associate with the Center for Population Studies, where she leads the Applied Policy and Community Research Lab. Additionally, Dr. Kafer is co-founder and co-director of the university's Community First Research Center for Wellbeing and Creative Achievement. Some of you may recognize her from her previous presentation at the Hunger Summit on the topic of the Mississippi Health and Hunger Atlas. Among Dr. Kafer's many research interests are linking community development, food systems, and health, and she is an internationally recognized scholar in the area of community resilience. Her work was recognized through her selection as a Carnegie Fellow, the first from Mississippi-based scholar. Dr. Megan Rosenthal serves in several capacities here at the university, including Associate Professor of Pharmacy Administration, Research Associate Professor in the Research Institute of Pharmaceutical Sciences. She's an affiliated research associate with the Center for Population Studies, and she too is a co-founder and co-director of the CREW. Dr. Rosenthal's general research interests include community pharmacy practice, implementation science, and patient-centered research. She's also interested in improving diabetes self-management and patient-centered weight management programs. We've asked Dr. Kafer and Dr. Rosenthal to present to us today, followed by a time for Q&A. The Q&A session will be facilitated by Ms. Lynn Wu, who's the Interim Director of the Center for Population Studies and coordinator of the Society and Health program. Before the presentation, I'm going to ask Ms. Wu to share any special instructions with you about that. Lynn?
Yeah, hi, good afternoon, everybody. Just real quickly before we get started, I just wanted to, for all of you to know that, so all of the attendees, when you enter this meeting, we are in a webinar format, so you should be seeing our presenters on your screen, and those are the only faces, hopefully, that should be showing up. When you have a question, if you scroll down to the bottom of your screen, you'll see a couple of icons you can click. You can either click raise your hand if there's a question that you might have. There's also the chat function that you can use to speak to all the panelists and the attendees if you'd like. And the other icon that I just want to highlight would be the Q&A section. And so that'll be a great opportunity that during the presentation, if something comes to mind that you want to ask our presenters, I ask that you put those questions in that box, and then all the presenters and your host, we all can see those questions. And hopefully during the presentation, if that's something that gets answered, or that during the Q&A sections after the presentation, we can address some of those questions. Also during the Q&A section, if you raise your hand, I can give you permissions to unmute yourself, and you can ask that question live also. So I think that's about all for the housekeeping part of it. So I'll pass it on back to John.
All right, thank you, Lynn. So with this, I'll turn it over to Dr. Kafer and Dr. Rosenthal.
So let me know if that's showing up okay for everybody. Okay, excellent. So thank you for that lovely introduction, Dr. Green. Megan and I are going to present part of our work. It's a significant part of our portfolio through CREW. But I think, and I'll speak just for myself, food as medicine is not necessarily in itself a novel idea to me, but a new way to conceptualize the work that Megan and I do. And so we're gonna hopefully set this stage with sort of some background information and an example that future presenters for this series will be able to build on. So that's our goal today, and we'll have plenty of time for Q&A, so no worries. Okay, maybe. There we go. You gotta hit it multiple times. So I know one of the things that I struggled with when coming to this realm is I had always heard the term food as medicine, and you will see I think often food as medicine and food is medicine used interchangeably. But for me, the take home message here is that there are sort of two schools of thought around using or leveraging food systems as a way to improve health. And one really speaks to food, alternative diets, folk remedies, cultural medicines, medicinal foods. And often we see this in the food as medicine realm. And while valid and important, what Megan and I are going to talk about today and sort of set the stage for is more what is used in clinical research and health research and the food is medicine realm, where it's specifically referring to the clinical elements of health and how we leverage food systems and food access to improve particularly chronic conditions. And so we recognize that food is medicine, and we'll share some research on this, but there's not a great definition. So we pulled this one, and this is how we tend to conceptualize it, and how a number of not just clinical providers, but folks that work in chronic disease management tend to define food as medicine initiatives. And that's really the integration of food and nutrition into healthcare, so that it's a more holistic model compared to traditional clinical approaches. And so what we want to talk about are the reasons why. Why is food is medicine? Why is it an important initiative? Why are we here talking about it today? Why have we developed a whole series around food is medicine? And it boils down to sort of three key phenomenon that are increasing the vulnerability of populations in the US, but I think globally as well. So one is the increase in obesogenic environments, right? So when we've watched over the last 80 years, food systems shift. We've seen a lot more industrialization in the food system. We see a rise in fast and convenience foods that are much easier to access, and often in places where you don't have a local grocery store, you likely still have 2 or 3 fast food restaurants. You also see the exit of local grocers and a concentration of these retailers. And what this does is it creates food environments that make it very easy to have high calorie, low nutrient foods available consistently, but make it much more difficult to have access to fresh fruits and vegetables. This has led to a rise in chronic conditions epidemic. And I think many of us, especially based on the last series, the rising rates of obesity and its associated comorbidities of prediabetes, diabetes, hypertension, high cholesterol, high blood pressure, those increase the likelihood of premature death. They increase annual healthcare costs. We can expect that an individual who is obese is going to spend $2,700 more in annual costs just to manage that condition. And that doesn't account for the additional costs if they also happen to have diabetes or hypertension. And our response to that to date has really been an over-reliance on medical and pharmaceutical intervention. Despite the fact that we know that these are not just lifestyle, but community problems. These are problems of food systems, and they're long-term conditions. So expecting that there's going to be a medical intervention that is going to fix the problem quickly is not realistic, right? So we need to look at patients' conditions and make sure that we're looking at them systematically, which food is medicine allows us to do. It allows us to look at not just the symptoms of the condition, but also what are those underlying causes that are related to food. And then it helps us appreciate the quality of life limitations, right? And so it's not about a person making bad choices or about a person, a lot of like patient shaming and patient blame, but it's more about having a very real and sometimes tough conversation about the limitations that patients face in accessing food, and the limitations that places on the lifestyle changes that they can reasonably manage, to either prevent the condition or manage the condition. So food as medicine has been conceptualized as a way to do this broadly, and food as medicine initiatives are wide ranging. There are a number of them, but they tend to have three things in common. One is they focus on diet related conditions for the most part, right? So when we think about obesity, diabetes, pre-diabetes, all the ones we've mentioned before, they all tend to have a focus in treating, again, nutrition and food related conditions. The second thing is they tend to, right? Again, we're talking like law of averages, but they tend to address both access, right? Recognizing that it's not simply about telling a patient you need to do a thing, but it's about understanding a patient's ability to do a thing, right? So they address access in places like food deserts, or the new term is food swamps. And they address nutrition, right? So understanding that behavior modification comes through understanding the importance of nutrition, and that you have to understand the importance and the role of nutrition, but also be able to implement that knowledge. So food as medicine initiatives across the board tend to do that. And then the final thing, and this speaks to the access issue, is that food as medicine programs typically focus on at-risk populations. So when we say at-risk, we're talking about historically marginalized communities that may not have access to fresh fruits and vegetables. They may mostly have convenience stores, or if we want to use like a rural Mississippi example, I often think of Quitman County, where I've spent the last 4.5 years working. They're getting now, but haven't had a grocery store in a number of years. And so folks were either having to drive 25 or 45 minutes, or they were relying on fast food, dollar store, Dollar General, Family Dollar. And that increases the likelihood that they're going to have those health and nutrition related conditions. We also at risk, so low income, historically marginalized. And then what I want to do now that we have sort of a foundation, is I really want to talk about a specific type of food as medicine intervention as a way to talk about what folks are doing in the field. And that is the food prescription or food prescriptions. And so Megan and I, prior to the intervention that she's going to talk about, we did our homework, right? We wanted to understand what are food prescription programs, how are they used, why are they used, are they effective? And so what I'm actually going to present to you all today are findings from a pretty extensive scoping review that we conducted to give you a sense of what's the range in terms of food prescription programs, but also what works and what doesn't work. And then Megan will show you how we've utilized this information to really tailor a program that we think pulls from the best practices, but also addresses a number of those gaps. And so food prescription programs have lots of names. So in part, it's kind of hard to find information about them, because you never know what you want it to be catchy and snappy and folks to pay attention. So Food Rx, pharmacy, often they have a connection with local farmers, food pharmacy, produce prescription. But we want to present this one to you because it tends to be one of the more salient forms of food as medicine. And what we have found typically is that in this realm, food prescription literature and programs are dominated by those in nutrition and dietetics, which is good, right? Like the emphasis on nutrition and health and behavior modification. These are folks who are trained to do those things. But one of the shortcomings, as many of you know, living in rural Mississippi, not everyone has access to an RD. And so the folks who tend to be primed to deliver this programming may not be in the places that these programs are needed most. As I mentioned earlier, food prescription isn't a well-defined concept. There's general agreement that it's about increasing access to healthy food to at-risk patients. The how this is done, to what extent this is done, and the amounts of services that are delivered vary across program. The focus tends to be in these programs on fruits and vegetable consumption, and not so much like meats and dairies. And part of that is much more difficult to, it's much more difficult to get access to fresh fruits and vegetables. And so these programs tend to focus on that. They're also found primarily, the programs that are implemented tend to be found primarily in the Northeast and the South. So good news for us, I suppose. But the downside that we've found is that most of these are done in urban settings, in part because of the ease, right? There's population density, being able to procure food in larger quantities in urban areas, and being able to plug into a more concentrated area of nonprofits and folks who are wanting this to work. And ironically enough, they're typically connected to farmers markets, which we see more prevalent in urban spaces. So, that gives you a sense of the variety of food prescriptions that are available. And so now I want to talk about, in combing the literature, what are the things that seem to be highlighted and important successes of food prescription programs. And so the first thing I want to highlight is retention. So of the programs that we surveyed, most of them had more than 70% retention, which is pretty phenomenal in a research study. So they're doing a really good job of targeting the programs well and keeping people engaged and making it easy for folks to access the services and utilize the services. Most relied on either a referral from a medical provider or on screening through a medical condition. So they are, even if they're not using a medical provider, they are targeting medical conditions. And so that clinical piece that I think is really important in food as medicine initiatives, even if they're not run out of a clinic, is still being maintained by a majority of food as medicine programs. We also found that many participants had significant autonomy in their food options and choices. So a number of programs actually utilize a voucher system where they provided coupons or vouchers for folks to either use at the farmer's market or use at a local retailer, like you would a prescription. And so folks are able to make choices about what they're eating. And we know that when folks are able to make choices and they have some autonomy and some agency in what they're doing, the buy-in is a lot better and the outcomes tend to be better. We did see a number of programs experiment with mobile and delivery options, especially for the elderly. So that, I think, is another thing that's really great about food as medicine generally, but food prescriptions, in that they're flexible models, and understanding that not everyone is going to be able to come to a central location and pick food up. There are really good models for what mobile distribution might look like. And then we did find that most folks when they measured outcomes, saw significant improvements. Now, most of these folks measured fruit and vegetable consumption. So the fact that they did see significant improvement in folks actually consuming those fruits and vegetables is good, but even those who measured health outcomes saw significant improvements in health. So I want to talk a little bit about I started to call this like the good, the bad, and the ugly. And I was like, that sets up a really bad tone for Megan coming in to talk about it. So I said, well, the good, and then maybe the not so good. In the sense that these aren't bad things, but these are the things where we can improve. And these are the things where, as researchers, we can develop plans for how we might evaluate and improve the programming. So the first really, and I think for us is one of the most significant shortcomings of current food prescription programs, is that they're fairly short. So the average length is about 11 months, so just short of a year. But that takes into account some significant outliers. The median, right? So that the middle range really is about 6 months. So most programs are right at or below 6 months. And anyone who does sort of healthcare research or understands how long it takes to see improvements in health conditions knows that that's not long enough to really determine what kind of effect that participation in that program is going to have on health or health metrics. So we felt that that was something that needed to be addressed. The other one is that there's not really a lot of in-depth evaluation. So when we say that, we fully recognize that most folks had a set of outcomes that they were hoping to achieve in their food as medicine, specifically their food prescription programs. And they achieved those, but there wasn't additional digging into sort of the mechanisms behind that change. So for example, many of these programs saw an increase in fruit and vegetable consumption. And the idea was that would necessitate behavior modification, right? So that it wasn't just people were getting fruits and vegetables, but that they were cooking them, preparing them, and eating them. So then when the program goes away, the assumption is that these folks are still going to keep eating these fresh fruits and vegetables, because there wasn't really an in-depth evaluation of behavior modification, a sense of self-efficacy about being able to do these things on their own. And it still doesn't recognize the fact that if the program goes away, these folks still no longer have access. We also found the lack of standardization in how food as medicine initiatives were implemented. I mean, again, we like the flexibility, and Megan and I both understand that context is important to building a program that fits within a particular social, cultural, economic geography. But there's zero standardization in terms of what gets evaluated, what are best practices, and that ultimately becomes a problem because it's really hard for someone else to replicate a program when there's not standardization across space or some set of parameters on what are the best practices of setting up a food prescription program. And we all know that when something works and we have a good sense that food prescriptions do, you want to be able to replicate that and scale up. And right now we don't have that kind of information or details. And then the final sort of crux of food prescription programs, and this comes from interviews that we did last year with healthcare providers in Mississippi. And Mississippi is very special in lots of ways, but our healthcare providers get the same kind of medical training that most folks do. So we felt like they were a good case study for what are the barriers to really integrating providers into food prescription programs, right? To really embed this idea of nutrition and food systems into the types of care that individuals get. And one of the things we found in these interviews is that providers don't get nutrition training. They're simply really uncomfortable with making that call and importantly, having those conversations. They feel perfectly capable of doing a screening. They feel perfectly capable of writing a prescription for fresh fruits and vegetables. But when it comes to that necessary follow-up around behavior modification or discussions around nutrition, providers really felt like that they didn't have the proper training to be comfortable in doing that, and that it really wasn't in their wheelhouse. And Megan will talk more about this when we talk about the example program. But this is really a place where the sort of high touch behavior modification component really requires some additional expertise, such as a registered dietitian, which, as we know, is really hard to find in rural spaces. So I'm going to hand it over to Megan, and she's going to highlight our food prescription program in Charleston, Mississippi, which requisite logos. We wanted to go ahead and recognize the Walmart Giving Foundation, who funded this after many years of toiling. So Megan, I'm going to let you take it away.
Awesome. Thanks, Annie. So I guess that makes this part of me, or this part of the presentation, ugly, right? But it's not really ugly at all. It's a really exciting project and a program that we're incredibly passionate about, and honored to be able to present to you all here today. And so, as Annie said, this program, the food prescription program in Charleston, is actually a representation of a partnership that we've been working on for a good long while now, between some of us here at the University of Mississippi, the James C. Kennedy Wellness Center, the Charleston Rural Health Clinic, and by extension, the Tallahatchie General Hospital. And this is really the culmination of probably about 5 years of work for me and about 3 or 4 years of work for Annie in working through this relationship with the folks at the Wellness Center in Charleston. Next slide, please. So the objectives of our food prescription program were really to kind of build off of some of the issues that exist in the previously implemented food programs around the country, and see if we could, add to that body of knowledge and really begin to address some of the barriers or the concerns that we saw when we did that scoping review evaluation. So first of all, the objective of this project is really to create a systemic process for identifying and referring eligible patients into food prescription programs. Food prescription programs are problematic if you can't identify folks who would be, eligible and in need of this kind of service. Next, we are looking to track enrolled patients beyond the 6-month mark to generate long-term clinical health outcome data. As Annie alluded to, most health studies, and this is a problem in health studies just in general, run about 6 months. So it wasn't really a surprise for us to see that in the larger literature, that most programs run about 6 months long, because that's just kind of the standard. But we know if we're tracking things like reduction in weight or changes in blood glucose levels, that takes a little bit longer to kick in. And especially if you're talking about these changes coming from food versus a change in a medication or a prescription of that nature, they just take longer to materialize. And so that's why one of the reasons why we wanted to extend our program a little bit longer. And finally, we're looking to develop some mechanisms for sustaining these programs beyond the life of the particular project, so that consistent infusions of grant funding become unnecessary. And again, as Annie talked about, just because the program funding runs out does not mean that suddenly the folks who are utilizing those services find themselves in a position that they are able to afford and access those fresh fruits and vegetables that they were gaining through the program. And so really, this, for me in particular, is one of the most interesting and has the greatest potential of this program, is to figure out a way so that after we disappear, the folks that are in these communities that we're working with are able to continue to have access to these fresh fruits and vegetables that we know are so integral to in maintaining and improving their health. Next slide, please. So for this project, we're looking to enroll around 50 families who have or face some measure of food insecurity. And this looks to be approximately 200 individuals. And we made our calculations based on households of 4. But as you can imagine, not every household has 4 people in it. And so we have some households that go up and down from that kind of baseline or that kind of median number. Next slide, please. So our original enrollment process looked something like this. So we had intended, as Annie alluded to figure out a way that we could improve the identification of potential participants in such a program through a local clinic, providers at a local clinic. So first thing we did was we partnered with the local clinic in Charleston and had some conversations with the health professionals in that clinic about what this process would look like. And what we ended up, through those initial conversations, landing on is having the triage nurse administer a 2-item USDA food insecurity questionnaire to patients as they came into the clinic for any reason, really. It could have been like a well check, it could have been for something or related to a chronic condition they had. It didn't really matter, but we were anticipating administering this 2-item survey to all patients who came through the clinic. Once the patient had completed that questionnaire, the enrollment material, we had intended it for that enrollment material to be provided to the provider, to be given to the provider, to be given to the provider, and for the provider to discuss the program with the patient and see whether or not they would be interested or willing to participate. Then eligible and interested patients' information would be passed along to the project team and the staff at the wellness center so that we could follow up with them and work through the more rigorous enrollment criteria that we had to have them go through for the purposes of the project itself. So that's where we started. Next slide, please. So again, circling back to what Annie had talked about in terms of project evaluation, we wanted to kind of build on the work that had been done previously and extend it in a slightly different way than it had been done. And so we were looking at both individual clinical measures, talking about changes in A1C, changes in LDL or bad cholesterol, changes in blood pressure, and we're also going to be tracking weight, height, waist, upper arm circumference for participants in the study. And through our partnership with the Tallahatchie General Hospital, we're actually fortunate enough to be able to get some of those clinical measures, the HbA1c and LDL cholesterol, for the heads of our households that have been enrolled in the project. So that's incredibly exciting. Then at the household level, we're administering a number of survey instruments, the first of which being the CDC's Behavioral Risk Factor Surveillance System, or the BREFIS, if for those of you who might just use the acronym. And then we're also administering a food frequency questionnaire so that we can have some sense of kind of whether or not there is any change in some of the sociodemographic factors of the household, and also what does it look like, how much food are they consuming, and how does that change over the course of the project. Next slide. So in terms of evaluation time points, because we know that nobody likes filling out paperwork unnecessarily or coming and getting poked when they don't need to be poked, we've tracked our evaluation timeline out over basically to map out to every 6 months. So we're having a baseline measure for folks as they get enrolled in the study, and then every 6 months after that up to the 2-year mark. And that is, as Annie said, significantly longer than the bulk of the previously conducted food prescription programs. Hopefully we will see consistent improvements over time through this. Please keep your fingers crossed for us, but that's the idea. Then of course, there's a saying, and I'm going to mess it up, man plans and God laughs, right? So then the pandemic hit. And we were ready to go in the fall of last year, and then that all got paused as we were trying to figure out how we could deliver this program safely, whether or not people would be interested in participating in it still. And so we had to do some not insignificant revamping of what our original plans were. Next slide. So ultimately, the pandemic ended up delaying the kickoff and initial recruitment of people into this program by roughly 4 months, give or take a little bit around there. This also meant that clinic staff were stretched more thin than normal, managing just their regular patient traffic. And because, you know, the pandemic, of course, takes precedence over a food program that we're running, this was just not something that they could fit in addition onto their already full plates. And then, of course, as I'm sure this group is more aware than most folks are, this led to more urgent need than we had seen prior to the pandemic, as folks were having their hours reduced and you know, running into issues of, you know, getting access to any groceries at all, let alone fresh fruits and vegetables. And so with those things in mind, we've had to make a few adjustments. Next slide, please. So we have gone through plans B, C, D, and probably G so far, but we haven't finished recruiting quite yet. And so what we have done, understanding some of the limitations that the clinic staff have run into, is actually create rack cards that have been displayed in the clinic, so alongside a large banner outlining the program itself, so that people can self-identify if they are eligible and interested in participating in the project. And what they can do is take a look at this criteria, answer the questions you see there on the second image, and then leave this card with the clinic staff, the clinic front desk staff. And then on a weekly, semi-weekly basis, somebody from the Wellness Center will come up to the clinic, collect these cards, and they get passed back to us in to the research or the university-based team. Next slide, please. As a further consequence of this, we our enrollment period has been stretched significantly. So we had hoped to have all of our people enrolled in the program within about a 2-month time frame, which I know sounds ambitious and in retrospect sounds just ludicrous, but we're probably looking at extending our project timeline for roughly about another year. We've enrolled, Annie, correct me if I'm wrong, over 30 households at this point in time. So we're getting close to that 50 household mark, but we still have a little ways to go in that regard as well. Next slide, please. So lessons to date. And this one, I mean, in retrospect should have been obvious, but sometimes you just have to touch the hot stove before you realize the stove is hot. So adding one more task to an already lengthy list of things that folks in the clinic have to do is too much. And there's may not be a good mechanism within the clinic setting to have this work really proceed in an efficient way that is going to be consistently implemented. And this is one of the things that I've certainly noted in the work that I've done in community pharmacy settings. Pharmacists are really great about doing projects when the project is going on, right? We come in, we provide services, we provide reinforcement, we provide incentives to them to complete this kind of work, but then the project ends and they go back to where they were before, right? There's not that sustained implementation of these interventions over the long term. And so maybe we've begun to think through alternative ways of identifying people who may be eligible for food prescription programs in the future. We have been fortunate and have put to good use our great working relationships with members of the Wellness Center and other members of the community who have really spearheaded the recruitment efforts in town. These are folks who are intimately connected with various organizations and groups and schools within the community who can reach out to these people in a way that Annie and I certainly can't as people who are not from the community, to identify people who may be eligible for the program. And these are folks that those community members trust and know, as opposed to us coming in as outsiders to tell them about something they might be interested in participating in. We've also seen, and this I think is a testament to how well our program has been received, patients identifying family members who would be great participants as well. We enroll, somebody's auntie or uncle into the program, they like the program, and then they start telling their family members about it. And we have, probably of the 30 households we've enrolled, I would say at least a third, maybe a half, are related to each other in some way, shape, or form. And that is not through our recruitment efforts, but through the recruitment efforts of their family members to say, hey, this is a really great thing. You guys should come and take advantage of this opportunity as well. And then finally, the thing that we're particularly excited about as it relates to sustainability, and we haven't been able to figure this out totally yet, is that our biweekly food costs per household have been kept to roughly $30 a household. And this is based on math of 4 people within that household. Now, which is incredibly exciting and makes it something that could be manageable to be sustained over the long term. But before you get to, or before you are too skeptical of that number, because it doesn't seem like it's very much money, certainly, we plan this to work out in a way so that we are supplementing 3 to 4 meals per person per week. So this is not totally overtaking their grocery expenditures, but just adding to what they would have otherwise been doing at the under normal circumstances. So as Dr. Green and Annie also mentioned, this is part of one of the programs or one of the projects that we run through CREW. And this is something that we started almost a year ago now, officially, a project that Annie and I have worked on, and in conjunction with Dr. Green and Ms. Wu as well, figuring out how we can help communities in our state really take advantage of the knowledge and the infrastructure that we have at the institution to generate questions and research data and material that is important to them, and how we at the university can help connect all of you to those resources, whether that be Annie or I or any of the other faculty on our campus, to answer those questions and help you achieve whatever version of well-being that you're interested in achieving for your own communities. So we put the web address there for you all as well, and we'd be very happy and thrilled to talk to anybody who might have something that we might be able to help you with. So I'll stop there. Hopefully you all, I see a few questions. Hopefully you all have some really great questions, and I'm looking forward to our discussion.
All right. Hi, everybody. Now we're entering the Q&A session for both Dr. Kafer and Dr. Rosenthal. And there have been a couple of questions that's already been posted in the chat. So from Anna Kleiner, the question is, are the food prescription programs only currently available through public health clinics, or is it also accessible through private healthcare providers?
So that is an excellent question, and we're gonna tag team this. So currently generally food prescription programs across the US are accessible in a number of different models. So it can be universities working with clinical providers. We can also see nonprofits working with farmers markets. We've also seen some examples where they work with long-term care facilities or elder care. And so the arrangements that bring food prescription programs into vulnerable households run the gamut. Our food prescription program is currently only available in Tallahatchie County at the James T. Kennedy Wellness Center. And we do have plans, right, to scale up and pilot this in other places. We still minimally have another year of working out that scaling process and that sustainability mechanism, because when we scale this up, we don't want that scaling up to require grant funding. No, we'll take it. It's lovely if you've got it, but the whole point of this is to develop a program that can be scaled up and not require other dollars. And I'll let Megan talk a bit more about this, but part of that is working out clinical care, provider care, reimbursement through insurance. And these are all things that we're trying to work on, but it's a process.
So thanks, Annie. Leave me with the really hard part of that question. So what we're trying to figure out right now is how to, a couple of things, right? If and when and how we might be able to get insurers, both Medicaid and Medicare, to provide reimbursement or allocation of funds to go towards food prescription programs. And that would also be in partnership or in conjunction with private insurance or third-party payers as well. But we all know, for those of us who work in that world a lot, Medicare, Medicaid decides that it's going to do something, then everyone else kind of follows suit. And so we're working on that avenue to begin with. And one of the things that we know that they're particularly interested in receiving information around is what is the clinical impact of that, right? So how are we reducing blood glucose level or blood pressure, and how does that get modeled out to, reductions in emergency room visits or reductions in complications or around those chronic conditions. And that just is part of what we're doing in this project, to be able to gather some of that information and then create those models so that we could go to those payers and say, look, we have now saved, by doing having this reduction in blood glucose levels, we have potentially saved, or we might be able to save your company all of these downstream costs with a very minimal upfront investment. So that's the first piece of this. The other thing that we're also investigating is there a way within our rural communities in the state where access to fresh fruits and vegetables in small kind of remote communities is problematic? Is there a way that we could have some kind of supplementation program where folks who are in the community who may not be food insecure could buy into the program, and that cost could be the profit, I guess, for lack of a better term right now, that they generate through that program could then be used to supplement folks in the community who may not be able to afford the full cost of the fresh fruits and vegetables. And we're working through right now what that ratio would end up looking like, because it's beyond my pea-sized math statistics brain to do that kind of work, but that's really where we want to go, because we know that it's really going to take all of those things coming together to make a substantial difference in this area. Hopefully that answered the question, and if not, please ping us again and we'll do our best to retry.
No, I think that was great. That actually segued into the second question from Brenda Lynn about whether or not Tallahatchie County was the only place where it is available for right now, but the hopes of scaling up soon, or at least in a year. So the next question is from Austin Avery. Is the prescription program that Megan discussed, where do they plan on getting the volume of fruits and vegetables necessary to feed the 50+ families? And how frequently do they plan on providing access to the fruits and vegetables?
Yeah, so we, through our partnership with the James C. Kennedy Wellness Center in Tallahatchie General, we have access to Cisco, yeah, which is like what's the word I'm looking for? Like a bulk buyer, that we can go and place orders through the hospital there to get access to the food. And so that's how we've chosen to do this. And we know that, as Annie said, we know that a lot of these programs have historically partnered with local food systems to do this work. And I think in the future, doing something like that would be, where we would like to head. But that's, for now, we don't have the infrastructure in place to do that quite yet. And so we wanted to be able to have regular access to the a variety of fruits and vegetables that the folks in that community would be interested in eating. So we went that kind of wholesale route there. In terms of pickup, I think that's the second part of the question. How often are we providing the boxes or the materials? We do pickups every other week. And so we are in fact slated to go out next Wednesday to Charleston to do the next food delivery to our participants.
Great. Next question is from Jason Martin. Has there been any consideration for attempting the program in cooperation with a free clinic, like a low-income clinic?
Yeah, so on our end, it's really about the willingness of the clinical provider. I think in scaling up, we would absolutely love to work with clinics who are going to serve the populations that we're trying to serve in these programs. And so working with a free clinic, so the one in Jackson is what comes to mind, makes good sense and is something that we would absolutely be willing to explore. But the Wellness Center was a partnership that we had, and Catherine has been really phenomenal in leveraging the goodwill in the community that she's built. But yeah, we don't necessarily have a preference in the type of clinical provider. So
Yeah, and as a follow-up, he also asked, how could food prescription programs be added to existing food service providers, such as food pantries, weekend programs, hot meal services, etc.?
yeah, so that's actually a really good question. And I think very appropriate for this session, in the sense that Food is Medicine actually explores a lot of those options, right? Of full meal delivery, where you do diabetic friendly meals or nutritionally tailored meals. And that was something that Catherine and Megan and I sort of kicked around in terms of ideas very early on. Part of the limitations in that are having access to like a commercial kitchen. And so I'm thinking right now of like the food pantry in Quitman County. And so they have hot meals that they serve weekly. And I can see that being a food prescription program with a medically tailored meal being rolled into that. Absolutely. I think it's easier when facilities have the infrastructure to do that in a legal and safe way. And I don't know, we didn't have that at Tallahatchie. They don't have a commercial kitchen.
From Josephine Rhymes, we have, looking at Food is Medicine, is there or will there be a component of the program that will monitor food prep?
So we had plans to do that pre-pandemic, and running some programming within the Wellness Center. They actually have a kitchen in the center that is set up for folks to be able to come in and kind of take a cooking class, for lack of a better term, or watch the preparation of food in that setting, so that they can learn, proper techniques and new recipes and things of that nature. Given the fact that we are now in the winter and we're not allowed to congregate in groups indoors, we haven't done a lot of that yet, but we are planning on, we have tents and cooking stoves ready to go for when the weather becomes a little bit nicer, to be able to run some of these demonstrations outside, so that folks can have an opportunity to see that process, and then also try new fruits and vegetables, because we know that sometimes folks have just not tried certain things before, and so understanding what that looks like, and getting a chance to try it, low risk try it, is also part of that too. We have been in conversation with a number of the families that have been enrolled in the program already, and they report really great things back about the recipe cards that we include as part of the pickup for a lot of the deliveries. I think we try to do it kind of every other pickup. Are enjoying the recipes. They also are very frank, and we're incredibly thankful for this, when we miss the mark on things that we order. So I would say kale was not a hit with a lot of our families, which they were very gracious in telling us that kale's a no, and we have not ordered kale since we got that, since we received that information. But that tells us also that folks are using what they're picking up from us in their daily preparations, or in their meal preparations, in between the times we see them.
And just to add a little bit to what Megan's talking about, part of the outcome or the output of this project is to be able to put together a toolkit. So in the scaling up process, we don't necessarily have to be involved, in the sense that the idea is to streamline a lot of these processes, so that a person can pick up a how-to and they can start tailoring that to their particular context. And specifically in relation to the food conversation, we've been sending home food journals to help us understand how people are using the food, and like what types of meals they're using them, and how they're spacing it out, so that we have a better sense of what we order and how it's being used in the home in terms of the number of meals, right? Because I think one of the most challenging things for us in the early months of the program was getting the food order right, so that we weren't ordering too little of something or too much of something. And there are not any sort of readily available formulas for how you might calculate a per person or per household sort of food quantity for the appropriate number of meals. So that's one of the things that we're working on to help other programs sort of manage that piece. So the learning curve is not as steep.
Great. So this next question is kind of combining two of them, one from Jara Lee and Gia Matheny, about are you planning to partner with farmers markets or, in Jara's case, local farmers in this process?
So this is a tricky question for lots of reasons. So maybe I'll start with local farmers, in the sense that we've made some headway in that realm. We've started interviewing local farmers in terms of what kind of information, what kind of setup, what kind of volume they would need to invest in this kind of infrastructure. So similar to farm to school or farm to cafeteria or farm to hospital, farm to institution, this could plug into those systems, but in places where that infrastructure doesn't already exist, there's a lot of groundwork to be laid with farmers in terms of making sure that this is still an economically viable option for them to participate in, particularly in places that don't have a thriving farmers market, because they can't just produce for a food prescription program where the goal is to provide low cost produce. We couldn't be their only purchaser, right? They would have to have other folks that they're selling to. And so part of it is working out a much larger infrastructure. And we've started to explore that, and we will continue to explore that, because that is an ultimate end goal. We would like food and healthcare systems to be more integrated. But right now the infrastructure is not there, at least in the places that we're working. We recognize that the infrastructure is there in other places, but we don't currently work in those places. And to the farmers market. So when we initially developed this plan with Catherine, they had a farmers market in the wellness center. And one of the goals we had was to get that farmers market enrolled in Double Up Bucks, because that seems to be the route that many food prescription programs take. And they provide vouchers and they utilize the Double Up Bucks program. The struggle really here, and it's well documented in the literature, is that there are a few limiting factors with the partnerships with farmers markets. And again, I'm talking law of averages, not the really phenomenal farmers markets that we know exist in places. One is that they tend not to be in these really rural, remote places. So for example, Quitman County had a farmers market, and that's one of the places we would look to scale up, had a farmers market, but that's no longer operating, to my understanding. And we see this across the US, is that farmers markets tend to be disproportionately located in high income, suburban or urban areas. That and in part, that's part of the economic model, right? That they need to sell their produce at a particular price point. And what research has recently identified is that even when you do Double Up Bucks programs, there's two problems. One is that even with Double Up Bucks, it's still a pretty significant chunk of their EBT that's getting used in farmers markets. And so that's scary for folks who have an income limited resource for their food. The other is that even in rural places that have farmers markets, the EBT acceptance can be very challenging, right? That's a technological challenge that rural places face. And it can be economically, it can be cost prohibitive. And then the other is culturally. And this is well documented in the rural sociology literature, but for low income and particularly low income African-American households, farmers markets, even if they're at a price point, are not necessarily a welcoming place for them to come spend their money. And so we would love to partner with farmers markets. And if you are working with a farmers market that's doing some really innovative stuff, like we would love to hear from you and have that conversation. But those things aren't necessarily happening in the particular context that we are working in. And there's so much bandwidth, and those didn't happen.
So we have a question from Sunny Baker. Did you find programs in your research that did an exceptional job with cultural competency?
Well, they may have, but one of our issues is that those aren't things that they talked about. So we focus strictly on programs who were describing the logistics of their program. What I can tell you is that it was not part of the evaluation process that they talked about. And it wasn't often part of the way that they had set up the program. So surface level answer is no, none of them did, but they may have and not have written about it.
And again, from Jason Martin, do your participants have difficulty with transportation? In my experience, the families that have the greatest needs have the greatest amount of transportation barriers.
We do. We have a number of households that struggle with transportation, and we've so the way that we've mitigated that particular issue is we allow them to provide, have an alternative pickup. So we often have households that pick up for 1 to 2 other households that often live near them. And we've offered in some cases to do a delivery to the household if it was necessary.
Okay, we have a couple of comments. One from Erin Smith, who directs Double Up Mississippi, and so she runs the SNAP program via farmers markets and produce stands and grocery stores, and hopes to expand into this area into the future. And also, one more comment from Christian Owen. There are many definitions of what good food is. For example, how much of it, if at all, does organic food play a part in the goal for providing fruits and vegetables? In the areas you're working with, I would think the organic food might be harder to find, which is probably true.
Yep. Yeah, I absolutely agree with that statement.
And I think, so for this portion of the Q&A, those are the last few questions and comments. If you have more questions and comments, please feel free to put them into the Q&A box, the chat box, or raise your hand and I can give you permission to ask your question live. But if that is all we have for now, I guess I will pass this on to John for the next.
Sounds great, Lynn. Yeah, thank you. Well, thank you, everybody. Thanks. We're very thankful to Dr. Kafer and Dr. Rosenthal for a great presentation, and everybody for the good questions and lively discussion in the chat and making the connections and sharing ideas, which is what this is all about. To kind of wrap us up today, we've asked for kind of concluding comments from Brenda Smith at the Maddox Volunteer Center and Tom Pittman with the Community Foundation. So I'll turn it over to Brenda.
Hey everybody, we're so glad that you're joining us today. Thanks to Annie and Megan, that was great. My head is kind of whirling thinking about how does this connect with some of our other nonprofits and that kind of thing. We appreciate you letting us join in with you today and share some of this information with so many food pantries, nonprofits throughout Northwest Mississippi, but even across the state, because we have gained viewers and participants outside of our normal counties, so to speak, outside of the Delta. So thank you. Having this research, I think, is so important for our food pantries, for our nonprofits to back up what we know. You know, we know that we need healthier food. We know all of this, but having this to back it up is very important to know that we can make a difference. Thinking about the programs that are out there, I'm sure that we're going to have a lot of them that are want to connect and say, how could we be a part of this? How could we maybe replicate part of this program with what they're doing at this particular point? And our mission at the Maddox Foundation Volunteer Center, which is part of the hubs for the Connect with Volunteer Mississippi, is to provide support. And that's our important mission there, that we support the nonprofits, the food pantries, to help them to connect with programs, to help them to find ways of providing healthier food, and even move toward the food as medicine. We're probably not there yet, but in some cases we might be close. So thank you. We appreciate that. And I want to tell the our nonprofits and the food pantries that are connecting with us today that if you need assistance and have questions, we'll be happy to help you connect with the Center for Population Studies, Delta Directions, and move forward with that. Raising awareness, I think, is the main thing that we've done today. So thank you for that. And I'll turn it over next. Tom Pittman, I think, is going to come next.
Yeah, thank you, Brenda, and thank you, John. Yeah, just to very briefly, back in 2004, the Community Foundation's first big project was to try to reduce obesity in children in our 11 counties. And pretty quickly, we discovered that food was an important aspect of causing and reducing obesity. And we learned that term, food is medicine, more than a decade ago. So it's been something that we've kind of worked on off and on and hit or miss. And we really appreciate this organized effort from the University of Mississippi and Delta Directions. And I've often told people the best grant we ever made at the Community Foundation was to grant, I think, about $3,000 to Catherine Mooring to start her community health assessment in Tallahatchie County in 2012. And she took it and ran with it, as you all have praised her for her work in this particular project. But she took it and ran with it, found out what was needed. And by the way, Tallahatchie County ranked number 81 out of 82 counties in Mississippi for health at that time. And so Catherine ran with it. And part of it was to get the funding and develop the state-of-the-art James C. Kennedy Wellness Center. And I would commend anybody who's not gone to Charleston to see that center and the work it's doing. Please go. You'll be blown away by the work that's being done in Tallahatchie County and Charleston. And so it's really very gratifying to see her work and our little $2,000 or $3,000 kind of being multiplied, not only in what's being done in Charleston, but now this research that has tremendous import for the whole area, for the whole state, for the whole nation. And so thank you for setting the program up, and we look forward to providing whatever support we can. So thank you all.
Okay, well, thank you, Tom. So to wrap up, I know there's been questions about whether this is being recorded, and it is indeed, so that we'll be able to share this with folks who want to refer back to it. We are in the midst of organizing the next session. We're not ready to announce the date yet because we're still trying to work out some of the details, but please know that we'll follow up with everybody who registered for this event for the future ones. And also for some of you who are involved with programs and you want to share the information and you're interested in being a part of a future panel, let us know, because that's part of the purpose here is to network and share information and get the right people together. So with that, we want to say thanks, and we hope that that you're staying safe, and that maybe a break in this weather will get you outside. With that, goodbye, everyone. Have a good weekend.